Now that you have completed the FCCM exam successfully, which is the Fellowship of the College of Critical Care Medicine, welcome to the Advanced Fellowship in Intensive Care Medicine, and it is a privilege to appear for this exam. I am Dr. Praveen Jain. I am the chairman of the Critical Care Education Foundation, and I will give you an overview of the Advanced Fellowship in Intensive Care Medicine 2025 onwards. The journey started in 2002 when we started the Indo-Australian Critical Care Training Program with the help of friends from Australia, George Morgan, Bala Venkatesh and Chris Joyce. You must have heard people say that in order to be fair in an exam, everyone must be given the same test. So if all the animals in the jungle were told to climb the tree, the monkey would be happy and you can see that he's elated. But it is unfair for the rhinoceros, the elephant, the crocodile and everyone, because it is not a reflection of their talent. If you judge a fish by its ability to climb a tree, it will live its whole life believing it's stupid. Actually, the test is stupid. The fish should not be evaluated the same way as you would evaluate a monkey. That is why the critical care exam consists of various diverse components to evaluate all different aspects of an examination. There are two theory papers of 100 questions each, and it differs from the FCCM theory paper because in FCCM all the questions are best of 4 type, whereas in AFIC exam you have 80 best of 4 types and you have 20 true false or K type questions. The details will be discussed when we discuss theory. There the coverage in theory is very extensive. You have cardiology, neurology, pulmonology, gastroenterology, endocrinology, procedures, the recent guidelines and trials, important trials, etc. that are there. The OSCE stations are similar to the FCCM which you have given, but the stations are slightly different. The hematology, coagulation, equipment and drugs in ICU which were there in the FCCM exam are not going to be there in the AFIC exam. Instead, you have a wider range of graphs which include the ventilator graphics. You have medical statistics, hemodynamics, echocardiography and ultrasound, and microbiology and antibiotic selection. Like the FCCM, you also have a communication station, but there's a difference. In the FCCM exam, the communication station dealing with the relatives and communicating with the relatives. In the AFIC exam, there's a very high chance that the communication station will involve a scenario where you have to interact with your staff members, your residents, your nurses, or the hospital administration on an administrative issue. The e-cases are again similar to what you may or may not have done in the FCCM exam. In the past, it used to be a hot case and viva. So if you haven't done it, this will be discussed in the orientation. It's a mix of bedside cases and vivas. For the AFIC exam, you have two long cases of 30 minutes and you have two short cases of 15 minutes each. You're all familiar with the tortoise and the hare story there. The reality is ultimately both of them cross the finish line. It's just that the turtle takes a longer time. And if our criteria is anyone who can reach the finish line is a winner, then you do not give enough credit to the speed of the rabbit or the hare there, And so an important component of any examination is to do the skill, perform the skill in a fixed amount of time, and that time is equal for everyone. Time is an expensive commodity in the ICU duties of a doctor. A doctor typically has to see anywhere from 8 to 20 patients. He has to review all the investigations. He has to talk to the family. He has to talk to the consultants, etc. And if he is going to take 1 hour per patient in examining the patient, eliciting the signs, etc., then he will never be able to finish seeing all the patients even once. And that is why our students are taught to perform the necessary skills in a limited time, which means examining a patient, for example, in 7 to 10 minutes. This time management skill is unfortunately not taught in many of the courses. The exam used to, in fact, consist of these 5 components. We had the logbook, and if you cannot do the logbook, the academic diary. You had the theory or written component. You had the OSCE stations. You had just 6 stations at that time. You had clinical examination. In the FCCEM, you had 1 to 2 cases, and you had 4 viva stations. But this is now changed. The clinical cases, or the hot cases they're popularly known, and the vivas, totaling about 40% of the weightage, have now been removed from the examination from this year onwards. In their place, we have communication worth 10% of the weightage and e-cases, of which in the FCCEM exam you will get 1 long e-case and 2 short e-cases. The long e-case of 30 minutes and the short e-cases of 15 minutes each, and a total weightage for e-cases is 30%. So totally 40% was taken out, 40% has been replaced in the new exam from 2024 onwards. The logbook is a very important component of this examination. The FCCEM and the AFIC, the Advanced Fellowship in Intensive Care, and we will be dealing with this in details in a separate lecture. Just some words of advice. The logbook is very important. Do not delay making your logbook till the last minute. Try to finish it in the first 6 to 8 months so that you have time to read. Logbook must reach the college at least 2 months before the expected exam dates, and the full logbook must be sent not physically but on a pen drive to the college, and also transferred using transfer websites like vtransfer.com. Put your best efforts in the logbook and try to get 100% marks, so that is 10 out of 10, because it reflects you and your performance throughout the year. Some candidates, especially those who are living outside India and working outside India, may find it difficult for security and institutional policy related issues that they cannot take patient data and submit it in the logbook. For them, an alternative is the academic diary. This too is dealt with in detail in the separate lecture linked with the logbook, so you can go there. If you have an issue with the management of your hospital not giving you access to data, then you need to contact the college and take permission for yourself to submit the academic diary as soon as possible. The theory exam is usually held 1 month before the practical exam and is clubbed with the crash course, which is the crash revision course, preparing you and getting you familiar with the examination system. It's very, very, very important to attend the crash course which is held, so that you are not taken by surprise when you see a different system than what you had for your MBBS or MD exams. The theory exam is held approximately 1 month before the practical exam, along with the crash revision course. You have 2 theory papers of 2 hours duration each. Each paper consists of 2 sections, section A and section B. Section A is MCQs of the best of 4 type. So one of the options given to you is correct, and attempting such an MCQ should not take you more than 1 minute. Section B, which consists of approximately 20 questions, are true false type, so also known as type K questions, where you will have 4 options and you have to evaluate each option as being either true or false. You should not spend more than 2 minutes attempting a type K question. How is the marking done? Well, if you get all 4 correct, then you get full 1 mark, and if you get 3 correct and 1 wrong, then you get half mark, and anything worse than that you get 0 marks. The theory paper for the AFIC exam, paper 1 consists of the cardiovascular critical care, pulmonary critical care, gastrohepatic critical care, hemato-oncology, common problems in the ICU, surgical critical care and trauma, and critical care pharmacology, toxicology, and environmental injury. Paper 2, which also consists of another 2 hours, is held immediately after the paper 1 is completed, giving a gap of half an hour or so in between. Paper 2 consists of neurocritical care, renal metabolic critical care, infectious diseases, critical care obstetrics, critical care endocrinology. And so far, this is similar to the FCCM exam. But what is different is, for the AFIC, you also have in paper 2 transplant critical care, landmark studies and guidelines, and critical care procedure. Here you can see the theory exam going on in a recently conducted exam of the FCCM, and the examiners are always standing by to see that it's a fair examination. These instructions are always given before the exam also. The FCCM only has the best of 4 MCQs, and the advanced fellowship in intensive care will have 80% of the questions as best of 4 and 20% as type K questions, where there will be various options and you have to say whether each statement is true or false. Remember to put your roll number on top of the sheet and sign at the bottom of the page. As I said, these instructions are given at the time of theory exams, so don't worry about it. This is how the AFIC theory paper looks like. You have section 1 and section 2. There, section A consists of MCQs best of 4 type. So basically, it's a 1-page answer sheet, and on top you must put your roll number or your unique identification number which has been given to you, and it's also there on your ID card. You have 4 options A, B, C, D in front of the question number, and you must then fill it with a recommended gel ink that is there, and you can see that you cannot cross it or tick it, and you cannot incompletely fill the circle. The whole circle has to be full as shown in here. There's the correct method. In the AFIC theory papers, you will have 20% of the questions as type K questions, where there will be a question and there will be 4 options. You have to decide each one, is it true or false. So regarding SIMV ventilation, should tidal volume, the set tidal volume should be 6 ml per kg actual body weight. I think it is false, so it's F. It may be used for patients with raised intracranial pressure. I feel it's right, so true. It's a form of volume control ventilation, true. Inspiratory flow decreases exponentially, false. So how do I translate that? This is what my answer sheet will be like. Whatever is true, I will color it. And if it is not colored, that means not true, that is false. The way to do it is, whenever you select a circle, you must completely fill it inside. Not tick it or cross it, not half fill it, fully fill it. This is very important. This is how the AFIC answer sheet will be like. Next 20 questions, so the previous 1 to 80 obviously are best of 4. The next 20 questions, 81 to 100, are type K questions, and they will be like this. Instead of A, B, C, D option, they'll all be true, 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 true. And if it is true, you need to color it inside like we just discussed. And if it is false, then you leave it blank. This just shows you how a typical answer sheet would look like, where wherever it is true, it will be colored, and if it is false, not true. And so the answer sheet submitted will look something like this. Instruction for filling the FCCM or the AFIC answer sheets: use a blue ballpoint pen only, not black, not a pencil. Darken the bubble completely, like you see here. Don't put a tick mark or a cross mark. Half-filled and overfilled bubbles will not be read by the software. Never use a pencil. Never use a whitener to correct your mistake. So be very careful before you mark. Writing on the answer sheet is not permitted. So you cannot write this is correct, made an error, whatever. And do not fold the sheet, which is called an OMR sheet. Let us try to understand the objective structured clinical examination component, or the OSCE component. There are 10 OSCE stations for the AFIC exam. You have some which are projected, like the X-ray, CT scan, MRI, USG, echo. They are projected for 3 minutes each, and then the question changes. You are not allowed to go back to the previous question. The remaining 7 OSCE stations, ABG, biochemistry, ECG, graphs, which are similar to the FCCM but includes a more diverse selection of graphs and includes ventilator graphics, hemodynamics, medical statistics, microbiology, and appropriate antibiotic selection for various scenarios. You get the standard 2 minutes to read, 10 minutes to write, and there are rest stations in between, 3 to 4 rest stations, also 12 minutes where you're not allowed to write at all. The X-rays and CTs for the FCCM will be projected, and for the AFIC, the X-rays, CTs, 2D echos, etc. will be projected. So you will not have 2 minutes to read, 10 minutes to write. Straight you will have 3 minutes per question, and there will be 4 questions per component. So there will be 4 X-rays, 4 CT scans, 4 echos and ultrasounds, etc. This is another exam where the X-rays are being projected. Sometimes the room has to be made dark, sometimes there is enough light there, but invariably the examiners check that you can see your answer sheets and you can write down. 3 minutes you get, and then the slide changes automatically. You cannot go back to a previous X-ray or CT. This slide shows you 2 popular formats for the OSCE stations. There may be a big table, single table, and then you move around it, or there may be individual tables and you move clockwise or anti-clockwise as the examiner or the chief examiner decides and has set the papers. When you're writing the OSCE stations, supervisors, senior examiners are there constantly watching you, plus the whole session is video recorded, so any cheating is not tolerated. These are 2 photographs showing candidates at the rest station. Please just relax. Close your eyes. Don't think about the past. Don't think about the future. Be in the here and now. Most important, do not write. I stressed at the beginning of this presentation that timing is very unique component of this exam, the FCCM exam and the AFIC exam. To be fair, every candidate gets exactly the same time, not a second more, not a second less. And therefore, timekeepers are always there, and when they ring the bell, that's the end. So whether I'm in the middle of a sentence or you're in the middle of writing, the moment the bell rings, pen down. Here I'm just showing you a typical OSCE that may be kept on the biochemistry station. A 67-year-old woman with long-standing diabetes is admitted for atypical chest pain and breathlessness. ECG shows sinus rhythm. Following is a blood report. What is the most likely diagnosis based on this biochemistry? 13 marks. Give 3 reasons to support your diagnosis based on this report. 12 marks. What you should quickly see, and you'll get about 2 minutes per question like this, not more. You should be able to pick up that there's an acidemia, the bicarbonates are low, so there's a metabolic acidosis. Quickly calculate the anion gap and find that it's normal. If you have a normal anion gap, you have to look at the urinary anion gap. It is positive, which means there's a renal tubular acidosis. And when you get renal tubular acidosis, you need to look at the urinary pH or the serum potassium. It is high, so this is renal tubular acidosis type 4. So your answer, when it says what is the most likely diagnosis for this biochemistry, is renal tubular acidosis type 4. Finish. That's what you need to write down. These calculations are not what the examiner is interested in. That you do on your rough page section of the answer sheet. Give 3 reasons to support your diagnosis. The 3 reasons I would give is there's a normal anion gap metabolic acidosis, she's a diabetic with hyperkalemia, and there's a positive urinary anion gap. 3 very solid reasons for diagnosing renal tubular acidosis type 4. If you're getting apprehensive, trust me, most of you after 6 months of training will be able to answer this in a minute or so. Another example of a biochemistry OSCE could be a middle-aged man suffering from cardiac arrest intraoperatively during an elective thoracotomy for a bronchial carcinoma. He required internal cardiac massage for 20 minutes before restoration of circulation. He was given adrenaline, calcium, soda bicarb, and lots of fluid during resuscitation. His plasma biochemistry at 12 hours and 72 hours are given here. And the question is, suggest 2 reasons for the low bicarbonate in the initial biochemistry. Well, bicarbonates are low, so there's a metabolic acidosis. You know he's had a cardiac arrest, so one of the reasons could be lactic acidosis. Okay, and second is a lot of fluids have been given in the resuscitation, so lots of saline, so hyperchloremic metabolic acidosis could be there, so saline resuscitation. This becomes obvious from the history, but in the exams you would really have to work up that the bicarbonate is low, there's a metabolic acidosis. What is the anion gap? You have a high anion gap metabolic acidosis. Look for corrected bicarbonate. You pick up a normal anion gap. High anion gap is because of lactic acidosis. Normal anion gap is because of saline resuscitation. So that's how you would pick up the answer to this. But the examiner is only interested in 2 reasons for the low bicarbonate. He doesn't want your calculations or how you arrived at it. So you would say high anion gap metabolic acidosis due to lactic acidosis and normal anion gap metabolic acid due to saline resuscitation. Now the second question is, what is the most likely reason for hypernatremia at 72 hours? You see, the sodium was 139, but in a matter of hours it goes up to 166. What could be the reason? It's very unlikely that so much saline has been given to push it up there. And so looking at the background, the history, etc., most likely reason is the diabetes insipidus, and with the possibility of brain death. Let us understand the logic behind 2 minutes to read first and then 10 minutes to write. Suppose you're at the ECG station and you've got 4 ECGs in front of you. You didn't get 2 minutes to read, so you started writing. You took the first ECG, you spent 4 minutes on it, you didn't really understand it, and so probably because you didn't understand it, you will get 3 out of 25 marks hypothetically. You come to the next one, you've never seen an ECG like this. In all probability, you're not going to get any marks. You score 0, and again you spend 4 minutes. So out of the 10 minutes, 8 minutes have already gone. You come to the third ECG, you know it fairly okay. You attempt it, you get 10 out of 25, but your time is up, 10 minutes. You did not get time to attempt the fourth one, which you knew very well, and you could have really answered it. So you get 0 because you didn't. The total score is 3 plus 0 plus 10, 13. So you get 13 out of 100 and you fail this OSCE station. Now let's look at an alternate scenario. You got 2 minutes to read. You saw these 4 ECGs and you said, first one I don't know. Second, I've never seen it. Third, I know a little bit. Fourth, of course, I know what it is. So when the 2 minutes are over and you start writing, you first attempt the fourth one, get 25 out of 25. Then go to the second one which you're more confident with, you get 20 out of 25. Then you attempt the first one, which is lesser of the evil, because the second one you have never seen and you're going to get 0. So you get 10 marks on the first one and the time is up. Now let's see how many marks you got. 10 plus 20, 30 plus 25, 55. Instead of 13 out of 100, you got 55 out of 100, which is more than 50. So you pass this station. That is the importance of 2 minutes to read. Decide which one you know, decide which one you don't know, and figure the order in which you will write the answer. In the OSCE answer sheet, there is an answer column and then there's a rough work column. Always start when you have a OSCE in front of you, and this is an ABG OSCE which says comment on the ventilatory status and explain the hypoxemia. You look at the PCO2 and you say, okay, PCO2 is high, so it's hypoventilating, I understand that. But to explain hypoxemia, you need to calculate the alveolar arterial gradient, where you find that it is normal. But these calculations are only for you to get at an answer. It's not what the examiner is wanting. He wants just an answer. So comment on the ventilator status. In the answer column, you will write patient is hypoventilating. Explain the hypoxemia. You say alveolar arterial gradient is normal and therefore there is no lung pathology. This low PO2 is secondary to hypoventilation itself. That's the answer. No calculations come in the answer section. The communication station is an independent, very valuable station. It's valuable not just to pass the exam, but it's also valuable for the rest of your life, because you will have to deal with relatives, you'll have to deal with other consultants, you'll have to deal with staff under you, and therefore both the FCCM exam and the AFIC exam have a communication component. What is the difference between them? Well, in the communication station for the FCCM exam, you will have a problem where you need to interact with the family members. Maybe you have to declare brain dead, maybe you need to ask for organ donation, maybe there's a complication that you're not aware of, you did not anticipate, and you need to explain to the family. Maybe you need to take consent for something, whatever. So in FCCM, it's interacting with the patient's family. In the AFIC exam, it's not really so much. You could have to deal with the patient's relatives, but more likely the problem would be departmental and interdepartmental. You may get a complaint that one of the resident doctors is very rude with the nurses, or the nurses bring it to your notice that he doesn't wash his hand before procedure, Or it may be you're given a problem that there's shortage of staff and you need to go and talk with the medical director or whatever. It's all about communication skills. At the start of the communication station, the scenario is given to you. You get 2 minutes to prepare the situation, understand the situation, plan a strategy. After reading and understanding the scenario, you then enter the room and interact with the examiner. The scenario could be that one of your residents in the ICU is abusive towards the nurses and the nurses have complained, or the nurses inform you that a particular resident does not observe aseptic technique while putting in central lines. Or it could be that the management is not responding to the shortage of nurses or doctors in the ICU, or any other issue that could be presented. And you will be then evaluated as to how you approach this with them, the logic that you use, and your grasp of the situation, etc. All of you will have received your academic ID cards, and these cards have your number, which is a academic ID number. They are also your roll number in the exams, so you need to always carry them for any program, whether it's orientation or it's crash course or it's theory exam or your practical exam. This must always be with you. From this year, the hot cases and the vivas have been amalgamated or brought together into e-cases, where you will be at a table, you will be given all the information, you'll be given paper and pen to make your notes, and then after a fixed time, you will then go to the table where the examiners are sitting and they will lead you through the discussion on e-cases. For FCCM, you will have one long e-case of 30 minutes and two short e-cases of 15 minutes. The FCCM exam and the AFIC exams are exams where the examiners treat you like colleagues. It's a very friendly environment. You have water that you can drink, the case scenarios, your notes you are allowed to keep in front of you while discussing, etc. The important thing is just be yourself and don't get very anxious, don't get nervous there. Do as you would in everyday life. Once the exams are over, the practical exams, all the examiners sit in a room and they evaluate your marks. The exam marks are re-examined by another set of examiners so that errors are minimized. What are the criteria to pass this exam? In order to pass this exam, you must secure 50 or more marks out of 100. You must pass in all the sections or at least in 3 out of the 4 sections, which means you're allowed to fail one section. But in e-cases, it should not be a horrible failure. It should be at least somewhere around 33% marks you should get. And anyone who fails 2 sections fails the whole exam, irrespective of if your total is 60% or 70% marks. If you fail in 2 sections, you are failed. I hope that gave you an idea of how the examiners declare pass or fail. It's very transparent and all the examiners can actually see the results being declared. Then there are envelopes saying that you have passed, you have failed, which are pre-prepared. And in fact, every candidate has 2 letters, one saying you have passed, one saying you have failed. If he passes, the fail letter is torn. If it says he's failed, the pass letter is torn, etc. That's how the dynamics and the working of the examiners is, so that we can declare the result quickly. Everyone is distributed these sealed envelopes and you open them up on your own and you have a look at it and you know what your results are. We don't use the word fail and pass actually, but we use the words successful and unsuccessful at this attempt. So you may be unsuccessful this year, next year you'll be successful. For that matter, next year you may top the exam. So the other important thing is that a time is declared later on where you can speak with the examiner about your performance. Overall, we believe our exams to be extremely fair. We are very proud of the high standards we have achieved over the past 20 years. We go to extreme lengths to see that it is fair, and examiners take a lot of pain. In fact, we spend about 4 to 6 months preparation per exam. We have no fixed percentage, and if you're good, you're good. There have been twice where we've had 100% result, but most of the time it's around 70 or 75 or 80%. There are no grace marks. So people have failed with 49.9 and the pass would have been 50. So because there's no end to giving grace marks. The examiners meeting is a very important and very popular component of the exam. It's held usually one day before the actual exam that the candidates give. It's about ensuring fairness of the questions that have been prepared, because one or two examiners prepare a section, and it is very important that it is not too tough, it's not too easy, the wording is not so ambiguous, etc. So all the examiners actually in a way give the exam that you are taking the next day, and even if one person is not able to pick up the answer and is not convinced that he would have done it in real life, that question would not be asked to the candidate. So we actually, the paper or the OSCEs are all prepared few hours before you actually give it, and no one knows what questions will be asked, except of course the chief examiner and the president of the college. Each examiner has a say in the wordings, the framing of the question, the structure. We have also observer examiners who are getting exposed to the system so that they can become examiners in the future. These are usually our past fellows. There is mechanisms to ensure confidentiality and prevents leak. We're very proud that in the last 50 exams that have been held, only on 2 occasions we found a minor infringement that was there and appropriate action was taken. Another important thing is you will never be examined by your own teacher. We make sure that you will not face your own teacher. What are the guidelines for the examiners that we give them? We tell them every time, be friendly, realize that candidates are nervous. Ensure questions that are put in a way that they understand. You cannot say the biochemistry was NAD, meaning no abnormality detected, or WNL, meaning within normal limits. Every region has its own short words that they use, so it may not be known to others. Try to see to it that you don't use these. Use clinical scenarios to assist and explain to the candidate. Ensure candidate stays on the track. If he's deviating from what your expected answers are, bring him back on track. Give candidates opportunities to gain marks. If he's getting stuck somewhere, move on to the next question. Give lifelines if something is going really bad. And so these are the instructions that are given to the. Now these are instructions, and it says Viva, but the Vivas are now replaced with e-cases. But the general guidelines are the same. Greet the candidates, make them relax, establish eye contact when asking questions, and if they're going off the track, bring them back on track. If you need to prompt them to get an answer, then just give them half of what they would have otherwise scored. Cover maximum questions possible, and any fatal answer. That means a fatal answer is something that would harm the patient or risk his life, then that candidate should not be allowed to pass. Now, in order to be fair to everyone, everyone must take the same test. There's another aspect to it too. If I'm going to ask one candidate about diabetes mellitus or DKA, and the other one I'm going to ask about adrenal insufficiency, it's not fair to both of them. We see a lot of diabetic ketoacidosis, so you're familiar with it. Don't see adrenal insufficiency as much, so it's a little tougher question. So in order to be fair and ask the same type of questions, we need to quarantine the candidates before and after the exam, so that those who have not given the exam yet do not come to know about what the questions will be asked. Here you can see one of the past exams where the candidate, this is the pre-quarantine area. and you can make out it's pre-quarantine because they're so busy reading. Last minute they're reading. Uh, and I will share with you as you train that the best thing that you can do before an exam is not to study at that time. Just relax and so that your mind can recall the answers. I hope in this picture you can identify some of your examiners. There are in fact two of your examiners here when they were students. So it's up to you to pick up the answer. These are successful candidates in one of the first exams where we started with these gowns. They're waiting for the ceremony to take place. This is part of the ceremony where the examiners are lined up and they clap for the successful candidates, and the successful candidates come and shake hands with all the examiners. Here you can see the candidates who are successful in the black gowns shaking hands with their teachers and examiners. Candidates who rank first, second and third get to address the rest of the students and the teachers and the examiners and give their viewpoints of how they found the exams. Again, this is part of the ceremony where the successful three top candidates cut cakes, and you can see the medals around them, the gold, silver and bronze medal. And these are precious photographs of all the successful candidates in a batch and a successful journey completed by our candidates and who have made a lot of friends amongst each other. In the AFIC, the Advanced Fellowship in Intensive Care Awards, you have the topper standing first gets the Professor Dr. P.K. Jain Award and gold medal. The second person gets the Professor Dr. Mita Mehta Award and silver medal, and the person coming third gets the bronze medal in the AFIC exam. In the AFIC exams, you have the Dr. Anurag Mahajan Award for standing first in or highest in OSCEs. You have the Aditi Jain Award for standing first or highest in the E-cases, and Dr. Sumer Chand Jain Award for standing first in theory. Overall, lots of medals and awards are given away at the convocation. They are a reminder of your outstanding performance. They help you display them in your hospital and for other people to realize where you stand nationally. One of our students getting the J.D. Sonawala gold medal, receiving the Bala Venkatesh award. Historical photograph now 2 decades ago where Dr. Mita Mehta stood first, and she is a student here, and her journey has been fantastic. She is from student to president of the college and giving back to the community. That's what the College of Critical Care and the Critical Care Education Foundation is all about. Everyone puts in efforts to train you in the hope that you will in return train other people, and so this cycle goes on. Successful candidates throwing their caps. The FCCM exam and the AFIC exams are life-changing exams. These 2 years that you spend learning, first 1 year for the FCCM and second for the Advanced Fellowship exam, will change you in ways that you may not immediately recognize. But when you are out in the ICU and you can make a diagnosis quicker than your colleagues, you can make a diagnosis where people have missed. You will save lives, and we will be very, very proud of your achievement. We hope that passing the Advanced Fellowship is not the end of our relationship. We believe it's the beginning, and we all look upon each one of you as an ambassador of the College of Critical Care Medicine. We'd like you to stay in touch there. If you have problems, then you're free to consult with your teachers or on WhatsApp group, etc. So you're beginning your journey now, and I hope I have given you an overview of what to expect in the next 2 years.